Usually when we talk about medical diagnosis, there's this expectation of like mechanical precision.
Oh, absolutely.
Like you break your arm, the x-ray shows a jagged white line, the doctor puts it in a cast, and the bone just knits itself back together.
Yeah.
It's biology playing by the rules of engineering.
Because the body wants to heal itself. You're really just facilitating a process that millions of years of evolution have already perfected for us.
Exactly. But then you step into the world of organ transplantation, and suddenly those evolutionary rules become your absolute biggest obstacle.
Yeah, it completely flips the script.
You are taking a living piece of one human being, wiring it into the plumbing of another person, and expecting the body to just, accept it. But the immune system is a highly trained assassin designed to seek out and destroy foreign invaders.
It really is. It doesn't know the difference between a deadly bacterial pathogen and a life-saving kidney. It just sees other.
It just sees a target.
Yeah.
Which sets up our mission for this deep dive. If you're listening to this, I'm speaking directly to you, the first-year medical student.
Welcome to the trenches.
We know you've been staring at pharmacology textbooks, trying to memorize immune pathways and drug classes, and probably feeling totally disconnected from actual patients.
It can feel so abstract at that stage.
Totally. So we're going to bring all of that theory into the real world today. We're going to master the high-yield pharmacology of immunosuppressants by treating a specific patient.
It's the best way to learn it.
We've got a great stack of sources today. We're drawing from a really comprehensive New England Journal of Medicine Pharmacology review, clinical guidelines from UpToDate, and a real-world clinical case file.
And this case is a fascinating one.
Let's meet your patient. His name is Earl.
So Earl is 58 years old, and his chart shows a pretty complex medical history. Type 2 diabetes, hypertension, and hyperlipidemia.
The tough combo.
Yeah, very. He's been in end-stage renal disease for 5 years, and he's required thrice weekly hemodialysis for the last 3. His current med list includes statins, ACE inhibitors, metformin, and semaglutide.
Okay, but today is a monumental day for Earl. He finally got the call. A deceased donor kidney is available, and the surgeon is prepping him right now.
It's a huge moment.
It is. But before we can even think about writing his post-op prescriptions, we have to understand the specific biological threat we're trying to stop. Because Earl is getting a kidney from a deceased, genetically unrelated donor.
Right.
And to me, that sounds like a massive red flag for his immune system.
Oh, the conditions are essentially a perfect storm for organ rejection. Think about it. When an organ is harvested from a deceased donor, it spends time on ice.
It's outside the body.
Exactly. It's deprived of oxygen, what we call ischemic time. So the cells in that kidney become highly, highly stressed, and they start shedding what are known as damage-associated molecular patterns, or DAMPs.
DAMPs. So
Yeah.
basically, the kidney is chemically screaming for help before it even gets into Earl's body.
That's a great way to put it. By the time the surgeon connects Earl's blood vessels to the new kidney, those DAMPs act like a flare gun. They alert Earl's immune system to massive tissue damage. Add the fact that the donor is genetically unrelated, and Earl's immune system is just primed to mount an overwhelming attack.
And the primary orchestrator of that attack, the commander of acute cellular rejection, is the T cell, right?
Yes, the T cell is the main threat here. In our NEJM source, the activation of the cell is described through the 3-signal model. And understanding these 3 signals is really the only way to understand how our drugs actually function.
Okay, let's unpack this. I like to picture the entire T cell as a nuclear submarine sitting in the harbor.
I like that analogy.
Right. So signal 1 is antigen recognition. The T cell has a receptor, creatively named the T cell receptor, or TCR. And that TCR physically docks with the donor kidney's foreign antigen, which is presented on an MHC molecule.
Exactly. And that physical docking event initiates a massive intracellular cascade. Calcium floods into the T cell,
Okay.
and that calcium activates an enzyme called calcineurin. Now, calcineurin is a phosphatase, meaning its entire job is to strip phosphate groups off other proteins.
Slipping away.
Right. Specifically, it targets a transcription factor called NF8 nuclear factor of activated T cells.
So those phosphate groups act like bulky padlocks, keeping NF8 out of the nucleus. But once calcineurin strips them away, NF8 is free to dive into the nucleus and start transcribing DNA.
That's signal 1.
Going back to our submarine, signal 1 is the captain inserting his launch key. The system is online, but the missiles haven't fired yet.
Because the body needs fail-safes. An immune system that fires on a single signal would just destroy its own host with autoimmune disease.
That makes sense.
So signal 2 provides that fail-safe through co-stimulation. Along with the TCR docking, a second receptor on the T cell called CD28 must bind to matching proteins, CD80 or CD86, on the antigen-presenting cell.
Got it. So a second officer has to turn their key at the exact same time.
Precisely. If signal 1 happens without signal 2, the T cell assumes it made a mistake and goes into a state of permanent sleep called anergy.
Oh, interesting.
But if both keys turn, we trigger signal 3.
The launch button.
Yeah. Signal 3 is the biological consequence of the first two. Because NFA is now actively transcribing inside the nucleus, the T cell starts manufacturing a cytokine called interleukin-2, or IL-2.
Okay.
The T cell secretes IL-2 into its surrounding environment, and then that same IL-2 loops back and binds to IL-2 receptors on the very cell that just secreted it.
So it's an autocrine loop.
Yeah.
It's literally hyping itself up.
Exactly. This binding activates the MTOR pathway, the mammalian target of rapamycin. And activating MTOR pushes the cell cycle from the G1 resting phase into the S phase, where DNA is replicated.
But that's when things get out of hand.
Right. The T cell begins massive, rapid clonal expansion. One T cell becomes thousands of alloreactive killer cells specifically engineered to destroy Earl's new kidney.
Okay, so to save Earl, your job as his doctor is to sabotage that submarine before it ever leaves the dock. The surgeon is about to reperfuse the donor kidney with Earl's blood. The flare guns are going off. How do we stop this cascade in the operating room?
Well, we initiate phase 1 of our treatment plan, induction therapy. Yes. This is a profound immunological reset. We utilize intense intravenous drugs right at the time of surgery to completely suppress the immune system's initial response.
So I look at the sheer intensity of these IV medications in the guidelines, and I have to ask, why do we take this approach? Why take on the massive toxicity of a chemical reset when we could just start Earl on his daily long-term maintenance pills the morning of his surgery?
What's fascinating here is that the immune system's reactivity peaks precisely at the moment of transplant.
Oh, really?
Yeah. The trauma of the surgery itself, combined with those damps released during the kidney's ischemic time, puts the body in a state of extreme hyperinflammation. Furthermore, Earl has been on dialysis for years.
Right.
His blood has been filtered through artificial membranes repeatedly, which often leaves the immune system highly sensitized. A gentle blockade with maintenance pills would be instantly overwhelmed.
Okay, so for a low-risk patient, say, someone getting a perfectly matched kidney straight from their living sibling, the NEJM review notes, you might use a milder induction drug called bezliximab.
Yes, that's common for low risk.
It just sits on the IL-2 receptor, blocking signal 3. But you're saying Earl's high-risk profile requires a much more aggressive intervention?
Exactly. We need active destruction of the T cells, not just a blockade. We achieve this with a drug called RATG rabbit, antithymocyte globulin.
Rabbit, like the animal.
Literally.
Yeah.
The manufacturing process alone is a testament to the extremes of transplant medicine. Scientists immunize rabbits with human thymocytes, basically human T cells.
That's wild.
The rabbit's immune system identifies these human cells as foreign and creates antibodies against them. We harvest those rabbit antibodies, purify them, and give them to Earl intravenously over his first few days post-op.
So we are outsourcing antibody production to a rabbit.
We are.
And when those rabbit antibodies enter Earl's bloodstream, they bind to a massive variety of markers on Earl's T cells. They essentially paint a target on every single T cell he has, triggering his own immune system to burst them open and destroy them.
Yes, it causes a profound rapid depletion of circulating T cells. You are wiping the slate clean.
It's a total reset.
Exactly. And to support this depletion, we administer massive intravenous doses of a synthetic glucocorticoid methylprednisolone to immediately shut down broad inflammatory pathways.
Got it.
We also give an intravenous dose of a drug called mycophenolate mofetil, or MMF, to stop any surviving T cells from replicating.
Okay, so Earl wakes up in the ICU. His new kidney is making urine. The surgery is a success, but we have a major problem now.
A huge vulnerability.
Right, because of the RATG, his T cell count is essentially 0. I mean, a simple fungal spore from his garden or a common cold could literally kill him. We can't leave him in phase 1 forever.
No, we absolutely can't. We have to step down the heavy artillery to a sustainable defense. We transition to phase 2, which is maintenance therapy.
Okay.
The gold standard for maintenance, the regimen prescribed to the vast majority of kidney transplant recipients, is known as the triple regimen.
Here's where it gets really interesting. Because using a single drug to suppress the immune system forever would require a dose so high it would be incredibly toxic.
Fatal in many cases.
So the triple regimen uses a strategy of, coordinated sabotage. By using 3 drugs that target entirely different pathways, we get synergistic immunosuppression. And that means we can use much lower doses of each individual drug.
Precisely. Let's look at the first agent in this regimen, the calcineurin inhibitor, or CNI. For Earl, we prescribe tacrolimus.
Tacrolimus.
Right. Tacrolimus permeates the T cell and binds to an intracellular protein called FKBP12. This newly formed complex then physically binds to calcineurin and completely inhibits its phosphatase activity.
It's snapping the captain's key off in the ignition. Signal 1 is totally blocked.
Exactly.
Without calcineurin, NFAT keeps its bulky phosphate padlocks, it stays out of the nucleus, and the cell never gets the blueprint to make IL-2.
And the guidelines note tacrolimus is preferred over the older CNI, cyclosporine, because it has lower acute rejection rates and avoids cosmetic toxicities like severe gum overgrowth.
Yikes, yeah, let's avoid that. Okay, so what's the second agent?
The second agent in this coordinated sabotage is the antimetabolite. We continue the mycophenolate mofetil we started in the OR, but transition him to an oral pill.
The MMF.
Yes. MMF specifically targets signal 3, the proliferation phase, by inhibiting an enzyme called inosine monophosphate dehydrogenase.
Wait, explain how that enzyme actually stops cell division.
Well, cells need guanosine nucleotides, the G in the ACTG alphabet of DNA, to replicate. Most normal cells in your body have two ways to get these building blocks. They can build them from scratch through the de novo pathway, or they can recycle them through a salvage pathway.
Okay.
Lymphocytes, however, rely almost exclusively on the de novo pathway.
Oh, so T cells don't know how to recycle.
Precisely. Inosine monophosphate dehydrogenase is the critical enzyme for that de novo pathway.
I see.
By inhibiting it, MMF selectively starves the lymphocytes of the raw materials they need to multiply without shutting down DNA synthesis and cell division in the rest of the body's tissues.
That is brilliant. You've blocked the ignition with tacrolimus,
Mm-hmm.
and you've destroyed the supply lines with MMF.
Right.
So the third agent is the glucocorticoid. Earl will take a daily oral dose of prednisone. Prednisone acts as a broad systemic dampener. It enters the nucleus of immune cells and actively suppresses the transcription of multiple inflammatory cytokine genes. It is like just flooding the entire engine room of the submarine.
It really is. Tacrolimus, MMF, and prednisone. Synergistic immunosuppression. In a textbook, it is a masterclass in targeted pharmacology. The drugs beautifully counter the three-signal model.
Right. Except we are not treating a textbook.
No, we are not.
We are treating Earl. And when you look closely at the pharmacology of these specific drugs, the entire regimen starts to feel like a massive contradiction.
It's the harsh reality of the field.
I mean, the sources explicitly state that tacrolimus, the absolute cornerstone of our triple regimen, causes severe vasoconstriction of the afferent arteriole.
Yes, it does.
It physically chokes off blood supply to the kidney, which over time leads to chronic interstitial fibrosis. So it is fundamentally nephrotoxic. Aren't we prescribing a highly nephrotoxic drug to protect the kidney? How does that make any sense?
This raises an important question, and it is honestly the most difficult paradox in transplant medicine. The very drug keeping the kidney alive immunologically is simultaneously starving it of blood flow hemodynamically. We call it the CNI paradox.
That requires an impossible balancing act. The therapeutic index for tacrolimus must be razor thin.
It is incredibly tight. Give Earl too little tacrolimus and his T cells wake up from their energy and destroy the graft. Give him too much and the vasoconstriction destroys the graft.
Wow.
Managing this requires obsessive monitoring of his blood trough levels. Early on, the guidelines target a trough level of 8 to 10 nanograms per milliliter. As the risk of acute rejection fades months later, you cautiously drop that target to 3 to 7 nanograms per milliliter.
But practically speaking, how do you manage that tightrope when tacrolimus is so wildly susceptible to drug interactions? It's metabolized in the liver and gut by the cytochrome P450 enzyme CYP3A4.
Yes, which is a major bottleneck.
So if Earl gets a minor fungal infection from his garden, and his primary care doctor prescribes an antifungal like clotrimazole, which is a strong CYP3A4 inhibitor, his metabolism of tacrolimus just halts. His blood levels will skyrocket into the toxic range overnight, choking off his kidney.
The clinical reality demands that Earl's entire healthcare team communicates flawlessly. I mean, every single new medication, supplement, or even dietary change like drinking grapefruit juice, which also inhibits CYP3A4, must be cleared through the transplant team.
The paradox gets even darker when you layer on Earl's specific comorbidities. Remember, he is 58. He has type 2 diabetes and hypertension.
Right.
And tacrolimus impairs insulin secretion directly from the pancreatic beta cells. you are taking a patient with pre-existing insulin resistance and shutting down his ability to produce insulin.
We combine that with high-dose prednisone, which further increases peripheral insulin resistance. It just drives his blood sugars through the roof. Up to a third of previously healthy non-diabetic transplant patients develop post-transplant diabetes mellitus, or PTDM, on this regimen.
A third of them.
Yes. So for a patient like Earl, who already has the disease, controlling his blood sugar becomes immensely difficult.
So what does this all mean? You're also dealing with his hypertension. The tacrolimus is causing renal vasoconstriction, which naturally drives up systemic blood pressure. So you have a hypertensive diabetic whose medications are actively worsening both conditions.
It's a catch-22.
How do you actually manage this on a Tuesday morning in the clinic? You can't just wave a wand and tell the patient to deal with it.
It becomes a lifelong game of chess. You actively manage the side effects while protecting the organ. For his hypertension, we lean heavily on specific classes of blood pressure medications. We utilize calcium channel blockers, specifically dihydropyridines like amlodipine.
Because calcium channel blockers actively dilate the afferent arteriole. You are using one drug to physically force open the blood vessel that the tacrolimus is clamping shut.
Exactly. You are constantly titrating. We adjust his metformin or semaglutide doses to fight the PTDM, carefully monitoring his kidney clearance. If his GI tract cannot tolerate the intense side effects of MMF, we might switch him to an enteric-coated mycophenolate sodium formulation to bypass the stomach.
And what if the tacrolimus is simply causing too much fibrosis at year 3 or 4? You mentioned earlier that we couldn't just switch him to an MTR inhibitor.
Right. Drugs like sirolimus block MTOR, but MTOR is fundamentally responsible for cell growth and division. If you inhibit it systemically in a diabetic patient, their ability to heal wounds plummets.
Oh, that's dangerous.
Very. They develop severe hyperlipidemia. A diabetic foot ulcer might never close. So instead, if the CNI toxicity is too severe, a clinician might attempt a CNI-sparing regimen using belatacept.
Belatacept.
Yes, this is a monthly IV infusion that targets signal 2, the co-stimulation pathway, allowing us to step down or even eliminate the tacrolimus.
It seems like every move you make to suppress the immune system opens up a vulnerability somewhere else, whether it is an increased risk of opportunistic infections, secondary cancers from the lack of immune surveillance, or cardiovascular disease.
Actually, cardiovascular complications are the leading cause of death in kidney transplant recipients, dwarfing organ rejection itself.
We really ask these patients to trade one terminal disease and stage renal failure for a chronic, highly managed medical condition.
We do. It requires incredible resilience from the patient.
So, to our first-year medical student listener, congratulations on surviving this journey. We've covered a massive amount of pharmacological ground today.
You really have.
We mapped the biological threat of the 3-signal T-cell activation pathway. We countered it in the operating room with phase 1 induction therapy, utilizing RATG to wipe the T-cell slate totally clean.
We then explored phase 2 maintenance, utilizing the coordinated sabotage of the triple regimen tacrolimus blocking signal 1, MMF starving signal 3 cell division, and prednisone broadly dampening the inflammatory fire.
And finally, we confronted the CNI paradox, revealing that practicing medicine isn't just knowing the mechanism of action. It is balancing the life-saving properties of these drugs against their relentless toxicities, especially in a complex patient like Earl with pre-existing diabetes and hypertension.
It's a lot to hold in your head at once.
It sounds utterly exhausting to chemically suppress a patient's natural defenses for the rest of their life.
If we connect this to the bigger picture, the current standard of care is a blunt instrument, despite its complexity. But consider the frontier of transplant research. What if we didn't have to suppress the immune system at all?
Wait, what's the alternative? The immune system will always recognize the kidney as foreign tissue.
Not if you reprogram the immune system itself. In investigational trials right now, researchers are exploring a protocol called mixed chimerism.
Mixed chimerism.
Yes. At the exact same time a patient receives the donor kidney, they also receive a specialized hematopoietic stem cell transplant, basically a bone marrow transplant harvested from the exact same donor.
Oh, wow. You are transplanting the donor's immune system alongside the organ.
Through specific conditioning regimens, we make space in the recipient's bone marrow, allowing the donor stem cells to safely engraft. The patient literally becomes a chimera, 2 genetically distinct sets of immune cells living harmoniously in one body.
So if the donor's immune cells are now circulating as part of the patient's own immune system, they literally teach the host body that the new kidney is self.
The clinical results from early trials are staggering. Patients who achieve successful mixed chimerism can be systematically weaned off all maintenance immunosuppression.
Wait, really? All of it?
Yes, within a year or two, they take no tacrolimus, no MMF, no prednisone.
That's unbelievable.
The CNI paradox is completely eliminated. They live with a perfectly functioning kidney and a normal, highly functional immune system.
Imagine holding a human kidney in the operating room, knowing that instead of declaring a lifelong pharmacological war, you've brokered a permanent biological peace.
It's the holy grail of our field.
That is the future of medicine you are studying to practice. Keep pushing through the pharmacology. We'll catch you on the next deep dive.